Okay, time to talk about our another type of disease, myotonic dystrophy. Now, this is usually abbreviated as MD or DM. Okay, DM will be again of two different types, type 1 and type 2. Before going on to the different types, let's talk about something in general. So, myotonia, which means it will affect muscle. Tonicity means spasm, and dystrophy will cause degeneration. So, now we have an idea what is going to happen in this disease. So, also very important epidemiological data, epidemiological data. It is about 1 in 10,000. Good. Now, also it is an autosomal dominant disorder. It is progressive in nature. It is progressive myotonic, or we can say myopathy. Now, as we just said, myopathies are different other types of myopathy, usually called as muscular dystrophy. So it is very easy to get confused among all of them. Myotonic dystrophy is a type of muscular dystrophy itself, so it is a broad term. Okay, within this there are plenty of them, many. Okay, we will focus more only on important one. Just remember the names right now. We'll talk about all these diseases someday later. So first is Duchenne muscular dystrophy. Okay, so muscular dystrophy is MD. Second is Becker's muscular dystrophy. Third is myotonic muscular dystrophy, or simply abbreviated as myotonic dystrophy, SDM. Myotonic dystrophy. Okay, now fourth one is facioscapulohumeral muscular dystrophy. Facioscapulohumeral muscular dystrophy, called as FSHD or MD dystrophy. So these are the more important one. Today we'll focus only on myotonic dystrophy. Now, so when we are done with this, so whenever we just say myopathy, okay, so there will be a progressive weakness, right? Progressive weakness and degeneration of most commonly skeletal muscle, but again other different types of muscle can also be included in it. For example, smooth muscle as well as cardiac muscle. Okay, so there is no such differentiation which particular one muscle will be involved in it. Okay, so we're done with this one. Now, we have already discussed its epidemiological data. Okay, now let's see what is actually going on with the person. So primarily, because all the muscles in the body are affected, okay, so there will be skeletal muscle or any kind of muscle weakness depending upon which type of muscle is involved. There will be cataracts. Also, there will be some endocrinopathies and cardiomyopathy. So usually there's one thought that there is degeneration of muscle fibers, right? So there has to be a heart smaller in size, but reverse happens. Okay, this usually doesn't visible in X-ray, right? So because of muscle getting smaller, muscle fiber get smaller. So, and because of internal pressure forces, which if this is your heart, okay, so all these pressure from the ventricle will be pushed outside. All these pressure will be pushing the muscle fiber outside, leading to enlargement of the chamber and ultimately leading to a thin-walled cardiac or heart. This is also called as dilated cardiomyopathy. And other signs and symptoms will be according to dilated cardiomyopathy. Now, enlargement of ventricles. Good. Now, very important over here to note is that what the term myotonia means. In the previous slide, we talked that myotonia is muscle spasm. However, it is involuntary contraction of muscle that is delayed skeletal muscle relaxation. So if there is delayed skeletal muscle relaxation, which means that once the muscle fiber is contracted, it remains in the same size for a more longer time, and because of this there is pain. There will be pain. Also remember is that this myotonic dystrophy is one of the most common type of muscular dystrophies, that too in adults, because the name was, it is a progressive in nature. So till adulthood, the only people who still lives is of myotonic dystrophy. However, there will be death due to some other reason. So in normal cases, this is our muscle fiber, right? And there are fibers. In this case, the overall size and or we can say overall muscle bulk is greatly reduced. Okay, with time progression. Okay, normal or early stages, and the muscle fiber keep on getting smaller and smaller, and there is tonicity increasing in size. So muscle bulk decreases and strength as well. Good. Now let's see what's actually going on in the body. Also one more thing, because the muscles stay in the contracted phase, so the muscles stay in the contracted phase for a longer time, long contraction of muscles or muscle fiber in particular. And because of this, there will be ultimately weakness of muscle due to utilization of the ATP within the ATP utilization within the muscle fiber. However, this is not just for one time so that the ATP can be replenished again. It is chronic, so again and again the same thing goes again and again, and it will result in the overall the gradual decrease in the size of muscle. Now let's talk about its pathology. What's actually going on in the body? So we just said there are two different types, type 1 and type 2. Type 2 is again much more severe form of myotonic dystrophy. So in type 1 there is repeats, CTG repeats. Okay, now guys, tell me, in the previous topics we just studied one more topic where was some sort of repeats. Do you remember? Yes, it was Huntington's disease or Huntington's chorea with repeats of CAG. Very important, right? Keep on remembering all those stuff. Very important. Now, along with that, we just talked that about 4 different diseases that have repeat type of disorder. So this is a base, so a trinucleotides, 1 2 3 nucleotides, trinucleotide base, trinucleotide repeat disorders. There are about 1 2 3 and 4 in number. We were done with Huntington's disease, then there was Fragile X syndrome, then we had the myotonic dystrophy, and lastly we had Friedreich ataxia. In Huntington disease there was CAG repeats, and Fragile X there will be CGG repeats. In myotonic dystrophy there is CTG in type 1. Okay, there's also type 2, and also lastly which is the Friedreich's ataxia, which is the GAA. So as I was talking that myotonic dystrophies of 2 different types. So in type 1 it is CTG repeats, which is much more common, and there's also one more type which is type 2, and there is CCTG repeats. Okay, let's erase this one just to remember. Okay, so these two are very important. Now what's actually happening? Okay, genetic basis of myotonic dystrophy. So there is CTG repeats, as we just said, CTG repeats. So let's say there is a normal gene which has C, T, G, again C, T, G, again C, T, G, and so n number of times. Okay, let's say it is CTG, CTG. Okay, now because it is CTG, so it is type 1. And in usual cases the normal is within the limits. However, in type 1 the normal number increase in size, and because of this the pathology comes into role. Okay, and this normal CTG makes up and form DMPK gene. Now DMPK stands for dystrophic myotonic protein kinase. and this will code for a protein, okay, which will play a role in muscle fibers to function normally. Okay, I guess it is dystrophin protein. One important fact that dystrophin is probably not dystrophin. This DMPK gene is the largest gene of body that will code for dystrophin. Okay, if this is the largest gene and it will code for dystrophin. So in case of pathology of let's say type 1, there will be again abnormal protein formation, and because of this there will be destruction of muscle fibers. Okay, so what is the important function of dystrophin over here? Dystrophin actually plays an important role in stabilizing muscle cell membranes, as it will become abnormal. Cell can't stay in normal phase for a period of time. Because of this, there will be eventual death, or if not death, at least atrophy of the muscle fibers. Okay, now we're done with this one. So again, more the number of repeats, more severe and much more earlier the onset will be. So point to remember is severity and onset of disease will depend upon number of CTG repeats. Higher the number, more severe the case and faster the onset. Okay, we're done with this. Okay, one more thing. The same thing was applicable on one more disease, that was Huntington's disease. Okay, if you remember, same over here, and it is also same for myotonic dystrophy. So myotonic dystrophy, same concept. Okay, now let's see some clinical features in much more detail. Again, clinical features in much more detail. Now, because of atrophy in muscles, so primarily the heart muscle will get atrophied and degenerated. Because of that, there will be there will be heart blocks. There can be also arrhythmias, and there can be dilated cardiomyopathy. Three main things to remember for the heart muscle. Then there can be also cataract formation. Okay, along with DMPK gene, there can be some also other genes involved within the same case, which will lead to abnormal protein formation, abnormal lens protein formation, Okay, and this usually can be explained by the other type 2. So we just discussed that there were again two types, So okay, let's read over here. So the type 2 is not that much common, it is again less severe, and there were CCTG repeats rather than CTG repeats, okay, which will code for CNBP gene. So here was DMPK gene, in case of DMPK gene, and here will be CNBP gene. If you can remember the gene name, that's fine. If you can't, that's also fine. Now, one more thing to note is that which chromosome number. So for type 1, these DMPK genes is found on chromosome number 19. Okay, this P looks like 9, so likewise you can remember. And CNBP is found on chromosome number 3. This B looks like 3, like this. So you can use any of the methods to remember. So 19 and 3 for myotonic dystrophy. So again, let's write it over here somewhere. DMPK gene, and DMPK gene is found on CHR19, and type 2 was CHR3, and the gene which code for it is CNBP gene. So this two should be remembered by you at least. And the main protein formation was the dystrophin gene, the dystrophin protein, right? Formation was altered in this case. Not gene, it is protein. Okay, dystrophin gets altered or abnormal, and because of that membrane stabilization gets hampered. Important. Okay, so cataract formation is done. Next is, as we just said, that insulin resistance will be there. Insulin resistance. Now why insulin resistance? So as we know, GLUT4 receptor is insulin dependent, right? So more greater the mass of muscle, more greater the muscle mass, more will be the number of GLUT4 receptor. Lesser the mass, lesser the number, and because of this there will be insulin resistance. Okay, hope it explains. So insulin resistance will be there because of it. Fine. Also there can be some other different types of abnormalities, because in everywhere there is muscle fibers, okay, within the arteries, veins, ducts, and so on. So all the different kind of signs and symptoms can be seen accordingly. So we are done with how the formation of insulin resistance takes place. Okay, then there can be also hypogonadism. There is usually cognitive impairment in severe cases. Muscles of mastications will also be affected, as well as there can be problem in swallowing, so dysphagia. And because of this, risk of aspiration increase risk of aspiration, which will again lead to pneumonia, and in severe cases again death can be there. One more mechanism can be there which can cause death is respiratory arrest, because of severe contraction in diaphragm. Now diaphragm is also again muscle, right? So this can also happen to diaphragm. Our GI system is again lined by intestine, which has the muscle there. So GI motility, or we can say dysmotility, cannot like this. GIT tract dysmotility. So peristalsis will be altered. Peristalsis altered. Patient can be presented with both diarrhea or constipation. Now because of this, patient can have IBS or IBD. Okay, we are done with this one. Now how to diagnose the patient? Let's move to diagnosis. Now first of all, we take the history. What was the age of onset and stuff like that. We check for the family history, which should be positive in this case. We check for sign and symptoms. We also do the physical examination. And once we are done with this, we can make a suspicion that the patient may have some sort of muscular dystrophy, but still not obviously, because we already discussed that there are also plenty more different types of muscular dystrophy. Okay, we discussed 4 major types, all these 4 main types, which should be in mind. However, in this case we can again exclude FSHD because it is much more locally affected disease. So scapulohumeral, again shoulder joint, is much more involved in this case. Okay, so we can again go for genetic testing, which is again gold standard genetic testing. Then we can check for CTG repeats in this, CTG repeats or CCTG repeats, CTG or CCTG repeats in DMPK gene or in CNBP gene, whichever. Okay, this will help us to differentiate which type is it. Okay, once it is done, you can also go for EMJ, electromyogram, to check for waxing and waning of symptoms of electrical signals within the muscle fiber. Now because of muscle dystrophy, CK will be increased. Yes, CK, the same as we studied in heart, that is creatine kinase will be increased. Also myoglobin can be increased because of muscle damage. More muscle will be damaged, more myoglobin, which is within the muscle fiber, will be in bloodstream. So same thing. We can also check for ECG changes, ECG changes, which would suggest of any kinds of arrhythmias. We can also check for cardiac sonogram to check for dilated cardiomyopathy, cardiomyopathy. Okay, and lastly we can go for muscle biopsy. Now how to treat? Again, there is no treatment available. Patient have a high risk of death. Only symptomatic management can be given, and the quality of life of the patient can be made nice by that. Yeah, that's all. Okay, I guess I have one picture for you guys. Let's discuss that picture. Okay, so in this picture, as we can see, there is a hand. Okay, let's say there is a hand. There's a hand, there is thumb, finger, 2, 3, 4. Yeah, okay. Okay, these are your thenar and these are your hypothenar muscles. Okay, let's say these one. This group of muscles, thenar muscles, hypothenar muscles. Now, what actually happen in this case? Whenever we give a tap, okay, to one muscle fibers, okay, one more concept. Usually, it begins in smaller muscle groups before signs and symptoms of bigger muscle group can be seen. So over here the muscles are small, so very firstly get affected, and because of that the symptoms can be seen much more early in the stage. So let's say the thenar muscle or the hypothenar muscle get affected, and we tap with an instrument or a hammer. Not that one hammer. Okay, let's say we have an instrument. Okay, and we tap onto that, and because of this tapping, as we know, the muscle was hyper excitable, and this hyper excitability was due to muscle and not by nerve. Okay, important concept over here again. Now as we just tapped onto it, so these muscles will twitch, and because of membrane instability, it will remain in this twitch a state for a longer period of time, and this will cause these symptoms: contraction of hand. This picture just refer for the hand, the same thing goes for every muscle group. Okay, so yeah, that's all. If you tap somewhere else, or somehow the person contracts some muscle, that muscle will stay in that uh, period or in that phase for a longer period of time, resulting in weakness, degeneration, tiredness, and so on and so. We already discussed all the different types of signs and symptoms. So yeah, that's all about myotonic dystrophy. See you next video, and probably the next video will be about tuberous sclerosis, and that's how we will complete 4 different types, I guess. Yeah, so we are done with this one. So our next topic will be TS, and after that we'll complete the nervous system, and then we can discuss about case studies, some quiz, MCQs will be there, and you'll master at least all these 4 types first. Okay guys, thank you for watching. Goodbye.